I'm Anthony Leeds, and I chair the Total Diet and Meal Replacement Europe organization. In a moment, we'll look at a few slides, but we're just going to pause for 1 or 2 minutes while some of the delegates join us, because as you know, often people don't arrive quite on time. With me are the speakers, Mike Lean in Glasgow, who's actually speaking from Cambridge today, and Henning Bliddal from Copenhagen, who's also waiting to give his talk. In a moment, when we have the slides, we'll discuss a little bit about the background to the organization and then what it does and what it's achieved when we move on. While we're waiting, any comments from our speakers who are watching and waiting?
I can tell you it's raining in Cambridge.
Okay, it's raining in West London as well.
Oh dear.
Perfectly sunny in Copenhagen.
Good.
Better weather in on the Mediterranean coast, actually, at present.
The Iranian coast?
Mediterranean, not Iranian. Yeah.
We have 49 participants now, and it is 1 minute past. So my suggestion is that we should press on. May we move to the next slide, please? So in terms of Zoe, you're going to move to the next slide, please. Housekeeping. When you wish to do so, please type your questions into the Q&A option, and we'll do our best to address them all at the end of the talks. If you'd like more information about the topics after the event, please send an email to the Secretariat. And if you have any technical problems during the event, please send an email to Zoe, who will hopefully be able to attend to them straight away, although she'll be busy changing slides and so on. Let's move on to the next one, please. So as I said, I'm Anthony Leeds. I'm a recently retired bariatric physician, and I now chair this organization, which is the European industry group for addressing issues relating to formula diet products for weight reduction. We have 2 speakers with us today from University of Glasgow, Professor Mike Lean, and from Copenhagen, Professor Henning Bliddal. Next slide, please. And here is the program. After a very short introduction from me, we're going to consider the issue of the use of weight loss in the medical management of osteoarthritis and some of the issues and some of the challenges that we now face. Then we're going to move on to a short summary of the direct trial and the implications of that, and what has also been done in other parts of the world already. Very, very encouraging information. So let's move on to the next slide, please. So I'm just going to make a very brief comment about Total Diet Replacement Europe. Next slide, please. Which, as I said right at the beginning, is an industry organization whereby the manufacturers and distributors of formula diet products who produce the total diet replacement products that are used in these clinical trials, and also the meal replacement products that are sometimes used for achieving weight maintenance. We work primarily to ensure appropriate legislation, because these products are controlled by regulations across the EU and across other countries. But our aim is also to increase the awareness and understanding of these types of products among healthcare professionals, and also among EU and national agency officials, and also other key opinion formers. Next slide, please. And in recent years, our major interactions have been to ensure the inclusion of a transition period for the 2017 Delegated Act, and also to work with Commission officials to request and achieve the revision of the minimum requirements for magnesium and essential fatty acids in line with the latest scientific evidence. And then we're currently liaising with policymakers to facilitate a review of the minimum protein requirement to bring it into line with the latest scientific research. So that's what we actually do. Next slide, please. But just before I introduce Henning Bliddal, let me just comment on these types of products. They are formula diet that provide all the food, replacing all conventional foods. Low energy liquid diet is an 800 calorie diet, or a little above that, maybe 1,000, sometimes as high as 1,200 calories. Very low energy diets are less than 800 calories, usually around 600 calories per day. They are low carbohydrate, but they are not very low carbohydrate. They usually provide 60 to 80 grams of carbohydrate in a 600 to 800 calorie diet, so about 40% of energy. They usually provide 60 to 80 grams of protein. That's again about 40% of energy and 20% of fat. All vitamins and minerals and essential fatty acids are provided, and that, of course, is the key thing, because it's very difficult to achieve a daily intake of all essential micronutrients if your energy intake is as low as 800 or indeed as low as 600. The result of this lower energy intake is there's a larger energy deficit between the body's requirement for maintaining weight and what is actually provided in the diet. The deficit could be between 1,000 and 2,000 calories per day. And this, of course, results, as you'd expect, in greater weight losses. These are typically, most of the recent clinical trials, between 1.3 and 1.5 kilograms per week. And the most interesting thing about this, of course, is that this becomes a highly motivating rate of weight loss. And certainly in my clinical practice, I've seen individuals who are very compliant as a result of a good achievement in the first few weeks. Whereas, of course, with conventional dietary guidance, very often people default after 2 or 3 weeks of trying hard on the conventional diet. So the high compliance, and this was confirmed in the 8-country preview study on prediabetes, in which 91% of over 2,000 individuals managed to follow the full 8-week total diet replacement diet. So let's move on now then to the next slide, which is, it's now time to introduce Henning Bliddal from Copenhagen, who's going to talk to us about osteoarthritis in relation and weight reduction. And Henning has been working in this area for many, many years. He's the director of the Parker Institute in Copenhagen, and has 2 years ago received a lifetime award from the Osteoarthritis Research Institute International, recognizing his contribution over a very long period of time to this area of research. So it's a great pleasure, Henning, to introduce you and to ask you please to review the evidence that you have in this very important area. Thank you very much.
Thank you, Tony. The question for us with osteoarthritis has always been to find some effective therapy, and unfortunately, this is still waiting to be found, but we have remarked that there's a definite link between obesity and osteoarthritis, and this is the starting point of a lot of studies we've performed at the Parker Institute in Copenhagen, Denmark. So the outline of this talk, where I'll review some of the data with you, is a bit about obesity and osteoarthritis. Then going through the Copenhagen program, I'll take you through some of our data, and finally talk about weight loss and knee replacement a bit. So osteoarthritis, as you may know, may affect any joint, but the most important is the knee, which is a social instrument that some of us will have difficulties with using in the later ages. It affects also in a heritable way the fingers, as you can see the nodules on these distal parts of the fingers, and some of you may have it, some not. It's in families running. But as you can see on the screen, the X-ray is a very worn down knee. So this is, of course, the end point of a long development of the degeneration.
Henning, can we just share your screen, please? We need to share the screen because we're not seeing the slide.
Okay, how do we do this? Will I?
So can you, it should be at the bottom or at the top.
Here
and
we
just
go.
Press share screen. That's
Share
it.
screen. Is that it?
Yep. And then you go over to your, that's it. And then if you go on to slide.
Okay.
Yep.
As I was saying, the connection, the common ground for knee osteoarthritis and obesity is definitely there, and it has been shown many times over the years that increasing BMI will leave you with an increased risk of getting knee osteoarthritis. Here in some studies from the US, where they actually could calculate that one point of BMI you increase will give you an extra 15% risk of getting knee osteoarthritis. I have the permission from the patients to show their pictures. This is before a major weight loss on this lady. This is a British calculation, epidemiological calculation of the risk for knee osteoarthritis. As you can see, it increases exponentially with the larger BMIs, to a very high value in these very obese patients. And also from this study, we know that having a major trauma to the knee increases the risk even further, and the odds ratios with meniscectomy, as you can see, is increased to 13. And it has been calculated again from these British results that a weight loss of 5% in this population would reduce the number of knee replacements by 1 in 4, which is quite substantially. On average, you can calculate again that each kilo you reduce weight, if you are obese, will decrease your symptoms of osteoarthritis by almost 3%. So it's a very good investment. And if we look at how we have performed this in the Copenhagen program, I could just take you through 3 phases with this program. Phase 1 is an acute study. It was a randomized controlled study comparing very low energy diet and low energy diets, then followed by phase 2, a 1-year study, again an RCT I'll go through with you in a moment, and then a very long follow-up, 3 years in the phase 3. So the first phase, we randomized 192 patients to these 2 groups, either VLAD or LAD for 8 weeks. And you can see it was the low end of the VLAD. Definitely, I tried it myself. It's rather extraordinary, and you lose a lot of weight in no time. We used formula diets, as Tony told you, from a company, but I think that most companies produce high-class dietary supplements like this. After the 8 weeks intensive phase, this was followed by another 8 weeks where we reintroduced normal ordinary diets at a low energy level. And then the outcome was actually after 16 weeks. And is it true that you can do this? It was in the Copenhagen program true that we could make people compliant with being in groups. This is our dietitian having a group session with some of the participants, and they lost weight like we haven't seen it before. And you will have to remember that these people have bad knees. This is not because they start exercising. This is simply acquired by changing the diet. 2 out of 3 of our participants reach a very significant relief of pain, and the Omurag-Dorasi response also involves a better function. Few dropouts, as Tony just told us. So with a 16-week program, you can make people a lot better in, should we say, no time, in simple way. We followed with DEXA scans and other measures the body composition, and the people involved in this trial lost fat, as you can see, not that much lean body mass, a little, I admit. And then, as an interesting observation, they became healthier. A marker of this was the level of vitamin D, which was reduced on average in the participants at baseline, but got into the normal range during the diet. So the supplements were a lot better than their ordinary diet. The following year, people were randomized, as you can see on the left panel, to 3 groups, a control group, a continuous diet group, they went on in their groups, and an exercise group. And unfortunately for the exercise people, they actually gained a bit of weight, but it didn't move much with the results. If you look at the right-hand panel, that they were still far better than at baseline with the symptoms. Then came the 3-year prolonged follow-up study. It's a bit busy, this slide, but they were divided into 2 groups. And what you see on the picture is the weighing the results weight at each time they were with the dietitian. And they were divided into a continuous diet where they had a meal replacement a day and ordinary diet reintroduced, and then some in the other groups, some 5 weeks every 4 months, they had a reintroduction of the lower energy diets. With this, we could actually, as you see, maintain the original weight loss for years with very small dropouts. And in our place, we were happy to say that knee replacement surgery rates were very low in all the participants in this study. So for a total of more than 4 years, people could lose weight and maintain the weight loss as long as we kept them in the groups. This was not because they got much more active during the trial. These are trajectories from the accelerometers. They were measured every now and then, and you can see there's a large variation of this, but overall they maintained their original lifestyle, which was not that exercise prone. So can we actually compete with the surgeons? We don't know quite yet, but if you go like they did in this British study to the waiting list and recruit people for a study of, should we say, the best pre-operative package for care in osteoarthritis, you can make people quite a lot better. 60 people were randomized 2-to-1 to an intervention and a control group. And the intervention, as you can see on the right, on the left side of this panel, was mainly weight loss and exercise. Some had insoles, some had adjustments of their analgesics, but in total, they got better during the waiting time for their operation. They were supposed to be operated, all of them. So the intervention group and the control group ended up with the surgeons mostly with the exception of 4 in the intervention group who actually refrained from knee surgery. They got so much better, they didn't need it, they felt. You can see that there's a trend with all the data registered in this study that people got better with the intervention, but the small groups prohibited large statistical significances to be found. So a bit extra about blood pressure, because this was an experience, we learned it the hard way with the first study groups we had, that when you go to a low energy diet, everything sort of drops for you. The blood pressure, you can almost get out of your antihypertensive medicine. You can drop the diabetes medicine, etc., during the phase where you are at the very low energy diet or low energy diet time. So we know that osteoarthritis is associated with an increased risk of cardiovascular disease, and actually people die earlier if they have a large BMI and osteoarthritis in combination. So if we again repeat these phases, we did blood pressure in all of them, and you may predict the cardiovascular risk using a British construct called Q-risk. It's calculated mainly from the blood pressure values, and in our case, we did per protocol analysis of all the completers of these phases from baseline throughout the 4.3 years until the final part of the light trial, that is phase 3. The interesting thing with the Q-risk is that you calculate the biological age as well as the chronological age, of course. And at baseline, people in our groups were plus 4 years. That is, their biological age calculated by Q-risk were considerably older than their chronological age. With the end of the study, they had actually gone down in age, so they got biological age 5 years younger during the 4 years they participated. So they ended up being with their usual chronological age, in spite of their BMI being enlarged. And this is a very interesting result. And you can see that the blood pressure were, the measurements were definitely lower all over these years. Thank you for the attention.
Thank you very much, Henning. I've just looked to see if anybody's asked any questions. There is an opportunity now for a few minutes just to discuss some of these very interesting results. And while we wait for people to type in some questions into the Q&A, let me just ask you, is weight loss as effective for hand osteoarthritis as it is for knee osteoarthritis?
There has been several attempts to elucidate a possible effect on the osteoarthritis per se. Of course, the weight-bearing joint knee is of most interest for the weight loss, but it seems that having a BMI above 30 will give you almost a double risk of acquiring hand OA. So there's some association. We don't know yet if you can relieve the hand OA by weight loss.
Yeah. And another interesting observation, and you've made it before, is the question of in both the trials, both your trials in Copenhagen and also the ones done in Edinburgh and Leeds, the compliance with the exercise guidance was not as great as with the other aspects of the management. What can be done to try to get people to be a little bit more compliant? Because as we know that exercise is important in helping people to maintain weight, and yet they don't seem to want to do it for more than a few days or a few weeks. What can we do to help people to do that?
Yeah,
Mike may have a comment as well.
Well, we have definitely experience with this over the years, and people ending up with knee osteoarthritis and overweight or obesity have a very sedentary lifestyle. And if you are going to change this, you'll have to do some regular, again, group work, motivating people for exercise. You can't just say, go back and do some exercises on your own. You'll have to do something about it. And I think this is a very important issue also with other means of weight loss, that you have to take care of increasing the exercise somehow. And this is a job for the health officers, the community. I don't think people can make it on their own.
Yeah, thank you. There's a number of questions now have appeared in the online Q&A. Peter Vedelsheim asks if the program that you've developed at the Parker Institute, is that likely now to become a standard part of your approach to management of patients who come to the rheumatology department at Frederiksburg in Copenhagen?
I have to admit that our administrators are not that keen on sponsoring the products, but we are doing trials with it, and we have conducted quite many studies in other sorts of rheumatological disease. It's highly effective against gout, and I think that it would be wise to include it in the prescriptions you may give to rheumatological diseases. Definitely.
Yeah. Philip Azir in France asks, what radiological changes were observed over the course of the program?
I'm afraid that in the beginning, at baseline, we actually hoped to reverse the osteoarthritis in the lighter cases. This was not seen. we had a varying degree of degeneration of the joint, and we couldn't reverse it, I'm afraid. This is until later, this is only a clinical treatment. You can treat the symptoms, you can't treat the structural reasons with this.
There's a question from Zoe Pearson: what types of exercise were actually undertaken? So perhaps clarification about precisely what was done or what was attempted.
Yeah, we worked out various programs for this, and in the end, we are trying to make individualized programs for people. If you see the grades of osteoarthritis in our studies, it varies very much, and the programs must be individualized to some extent. We are working right at present with trying to do aerobic training and trying to avoid, should we say, exercises provoking the knee. And this is interesting to develop programs like this.
Zoe also asked, what actually happened to the people who dropped out? Do you have any information about those who were less compliant? And of course, this is very important because we want to try to increase the proportion of people who stay in. So knowing why they dropped out would be very helpful. Do you know how did they get on over those 4 years?
Well, if you remember the various phases, we actually did some work of getting people in again before going into the phase 3. So if you drop out of a program like the ones we have conducted here, you may be recruited again or re-entered into the program after up to a year. I don't know what happens later on. I mean, people lose interest sometimes in participating in studies.
And then finally, a question about whether there was a problem with headache using the dietary program. So perhaps a comment on minor problems that occur with very low-calorie diets and very low-calorie diets.
I think the only significant adverse events that we experienced were bad breath for one, and obstipation for another. No sign of a headache really.
Yeah. And if I could just make a comment on the question of change of gut function, inevitably, if less is being eaten, the frequency of bowel opening is likely to change. And certainly in practice, what I used to do is ask people about whether they had problems with constipation or diverticular disease before actually starting the program. And if they did have a previous history, I would actually give an additional recommendation that they follow a dietary fiber stool bulking agent in addition, in order to prevent possibility of, for example, abdominal pain as a result of having diverticular disease and maybe diverticulitis. Mike, I don't know whether you want to comment on that because you've had extensive experience of using these in clinical practice. Mike Lean.
Yes, we offer, in fact, advise all our patients to take a fiber supplement to avoid constipation, and importantly to ask people if they have a previous history of constipation, because they're more likely to run into that as a problem.
Yeah.
It's a relatively small price to pay, but on the other hand, it's very inconvenient. I mean, people do complain a lot about constipation when it happens.
Yes, and of course we're dealing primarily in osteoarthritis with an older group who are more likely very highly likely to have some degree of diverticular disease and therefore to be at risk of episodes of diverticulitis. Because I think in the trials there have been 1 or 2 cases of presentation with abdominal pain, haven't there, Henning? Which needed investigation. But
we were lucky not to see any gallstones and not to see any diverticulitis over the phases I just went through. But it's known from larger studies that it is a risk.
Yeah. Okay, I think that covers. I don't think there are any more questions. No, so let's move on then. Thank you very much, Henning, for presenting those very important pieces of work.
Sorry.
Okay, most grateful. Thank you very much indeed. So we move on now to our second presentation, which is from Mike Lean, who's speaking to us from Cambridge, not from Glasgow today. Mike is somebody who's worked extensively in this area for many, many years. And in recognition of his contributions over many decades. He's actually just about to receive the rank prize for nutrition at the beginning of July. So well done on achieving that. That's great. And that particularly reflects the achievement in relation to pushing forward this whole notion of diabetes remission. I should add also that you founded the department in human nutrition at Glasgow University a long time ago. An enormous amount of work in lots of areas has been done, but really the thing for which you are known, perhaps, I may be getting it wrong, but is for these achievements in diabetes remission, but also pushing this out and rolling it out across the globe, because trials are now taking place in Singapore, in New Zealand, in Australia. We know that they're happening in the Middle East as well, and we know that they're also happening, for example, shortly in Malaysia. So well done on all of that, and perhaps you'd now like to summarize all of that for us. That would be good. Thank you very much. Thank you.
Thanks, Tony. That just maps out my scopes out my field for me quite nicely. I think I better go on with sharing the screen and giving a wee talk, and we can have a discussion afterwards. This is a pretty exciting time in diabetes, because we have really changed the management of this disease kind of nationally and now internationally in really a very short space of time. So here we go. My slides should be here. There we go. Title and some disclosures which are not very relevant to this, except that I do give some medical consultancy, which has payments to the university for the counterweight program that has provided the diet program that we used in most of our research trials, not all of them. The background: type 2 diabetes affects now over 4 million people in the UK, 300 million in the US, and I heard today that from Diabetes UK, the rate of diagnosis has increased by 40% in UK in the last 6 years. So the numbers are still rising, and rising rapidly in Western countries. And of course, in Asian and indigenous populations, there are genetic reasons why people develop type 2 diabetes earlier, younger, and with a lower body mass index. It's a much more aggressive disease for genetic reasons. It's this disease, what used to be called old age diabetes or maturity onset, and in my early clinical years, it was largely ignored by doctors. But we now realize, because it's coming on younger and earlier and more aggressively, it is a very dangerous, painful, disabling disease, and the complications are irreversible. They're permanent. It is also now the second most expensive disease to public health funders after cancers. That's putting all cancers together. Diabetes is a close second, and it's overtaken heart disease. It shortens lives, and perhaps we had forgotten how important this is, by on average about 5 to 6 years. But if you develop your diabetes young, under the age of 40, you will lose 15, you'll die 15 years younger than people who don't have diabetes. This is a life-shortening disease comparable to many big cancers. So we need to bear that all in mind. And it only occurs when populations gain weight. In the old days, when obesity was a rare thing, overweight was a rare thing, there was essentially no type 2 diabetes. Importantly, we have to also recognize that individuals are not all visibly overweight when they develop diabetes. If they are amongst those who are genetically predisposed to put a little extra fat into the wrong places, into the ectopic sites, which means into vital organs, rather than into the fat stores, which are under the skin, the subcutaneous fat, which is a safe place to put it. So some people aren't able to do that. They put it into their liver, their pancreas, their heart, their muscles, and that causes damage to all those organs. We know very well that weight gain is, as I mentioned, the main cause of the disease, and this has been beautifully demonstrated in the Nurses' Health study in North America, showing this colossal risk of diabetes as people develop a body mass index of 25, 30 and above. And this is not a comorbidity, this is a consequence, it's a causal relationship. And this slide also reminds me to say that worldwide, most people with type 2 diabetes have a body mass index between 23 and 27. And that is where the risk is rising really quite dramatically, up to 10-fold by the time they have a BMI of 25. And of course, very large numbers of people have this level of body mass index globally. So that is where the big task lies, is to deal with type 2 diabetes in people who are not in the conventional category of obesity. And we also know very well that modest weight loss, quite modest weight loss. Initially, the order of 6 or 7 kilograms, maintained quite well for 4 years here. 4 kilograms weight loss at 4 years. Was able to less than half the number of cases of type 2 diabetes developed over a 4-year period. This is the North American diabetes prevention study. There's almost identical results from Finland. And now a number of other studies, here they are in a meta-analysis, all showing a massive risk reduction from quite modest weight loss in trials. The diet itself doesn't really matter very much. It can be moderate in fat, low in saturated fat, rich in fiber, whole grain, Mediterranean diets. All of them are compatible with weight loss, which will prevent the onset of type 2 diabetes. A sidetrack here, just to mention physical activity, which Professor Bliddal also mentioned here. In these trials, weight loss is clearly the dominant effect, and that is primarily achieved by dietary change. There have been attempts to dissect out the effect of physical activity, and what this has shown is that on its own, physical activity does have a very small effect, not to produce remission, but to produce an improvement in cardiometabolic risks. And on its own, if there is no weight loss, again, diet or changing diet has a small effect to reduce cardiometabolic risk, but it is the weight loss through diet which is the dominant effect. And I think it's worth remembering that people who are living with overweight or obesity really have a hard time coping with day-to-day activities, carrying a lot of extra weight with them. They fatigue easily, partly because of the extra work, partly because of damage to their joints and muscles, the arthritis we've heard about, but also people with ectopic fat deposition in their muscle. They have fatty muscle. This fatigues early and becomes weak. So people with type 2 diabetes are weaker on average and fatigue easily compared to people without type 2 diabetes. So physical activities is hard to sustain for people who are overweight, particularly those with diabetes. However, if they are able to do that, and this is a study from the Look Ahead trial in North America, if they are able to add some physical activity to a weight loss program, this is mainly younger people, then they are able to maintain their muscle mass, which is good, and particularly to increase the type 1 muscle fibers. Those are the oxidative fibers that burn fat and burn glucose. So physical activity is a good idea if people can do it, but we should not be pushing people at the expense of their dietary advice. And we should focus on dietary advice if we want to achieve the greatest weight loss. We can come back to that. My interest in this topic went back to a very old study over 30 years ago, published from Scotland. And this looked at the weight loss which was achieved in the first year after diagnosis of diabetes. So patients were diagnosed, sent to a centre in Aberdeen, as it happens. They all saw dietitians. In fact, they saw a dietitian at every visit to the clinic, and they were urged to lose weight if they were overweight, which most of them were. And in this slide, you can see that if on the left-hand side, that was slipped off, if they lost no weight, they lost on average about 7 years of life compared to people who did not have diabetes. And as they lost more weight, they increased their life expectancy. We had data in that study up to 14 kilograms of weight loss, and those who lost 14 kilogram weight loss lived just as long as people who never had diabetes at all in the same population. So this suggested that quite substantial weight loss was able to basically overcome the disease and its clinical consequences to beat the diabetes. And that was one of the reasons why I picked 15 kilograms as a target for weight loss in the DIRECT trial. We knew not everybody could achieve it, but we thought this was an important target. The DIRECT trial was unusual in several reasons. It was conducted entirely in the community. Patients with type 2 diabetes were recruited from general practices in towns and villages. They attended their local practice. They did not come into hospital or see any specialists. They were very typical people up to 6 years from diagnosis, which is quite a big window, mean age 54, hemoglobin A1C 55 millimoles per mole on treatment, on their glucose lowering treatment, BMI 35, so they're pretty overweight. And on day one, we asked our patients to stop their diabetes and blood pressure medications. We had a simple protocol to reintroduce them if they were necessary, but in most cases they were not necessary because on day one, they started total diet replacement, about 830 calories a day, with a formula diet, with the plan that this should be followed for 12 weeks. And of course, if they were to do that and continue their medications, then there's a serious risk of hypoglycemia and hypotension, postural hypotension, which can cause really quite serious medical consequences. So it's important that they stop their medication and review the need for them as time went by. We allowed short holidays in that 12 weeks, so they could extend it if they had to. That's very flexible. We wouldn't do that with cancer treatment, would we? We then had a period of food reintroduction, meal by meal, going on to weight loss maintenance for up to 2 years. And over that period, they were seen initially fortnightly and then every 1 to 2 months by the practice nurse or a dietitian if there was one in their local practice. This is what the program looked like, the total diet replacement formula diet, very typical, nothing unusual about it, but it was nutritionally complete, so it's completely safe. Food reintroduction, that was when we introduced step counters to try to help people to increase physical activity if they could. And I'll shortcut the results here to say they did not. They were unable to increase physical activity despite being exhorted, encouraged at every visit. The weight loss maintenance phase, we chose to use a dietary advice which was essentially using the same ordinary foods which did not have any costs attached to them and which were familiar to the patients and to their families. And we felt that this would be the best way to achieve a long-term maintenance rather than using an unusual therapeutic diet. So it was not high or low in carbohydrate, about 50% of calories. As you can see there, 35% fat, 15% protein. Importantly, we did allow them to use a meal replacement once a day if they wanted to, as a way of maintaining their weight loss. And we offered relapse management. If they should gain over 2 kilograms in weight, we offered them a short period back on total diet replacement to get them back on track. This is how they did. And I think it's important to look at the individual courses of participants, as well as the mean effect, which you usually see presented in slides. That's the dotted green line. This is actually from the pilot study for DIRECT in a group of patients who followed total diet replacement. That's the black lines, until they stopped and went on to an attempt to maintain their weight loss. And you can see that the black lines were continued for about 100 days in most cases, but in some of those who stopped early, they're all at the top, and they tend to be the people who did less well in the long term. There was a proportion of people who did no better than they would have done just having been sent to see a dietitian. They obviously did not follow the program at all. That's about a quarter of the participants. There was also a larger number, perhaps over a third, getting on for half of the participants who did exactly what they were asked to do. They lost over 15 kilograms in weight, and most of them did that early on. So the people who lost a lot of weight early on did well in the long term. They had better maintenance of their weight loss. And that, I think, reflects Tony Lees' point here that it is very motivating to have lost quite a lot of weight. It becomes visible, people feel better, they have more energy, their muscles work better. So that's good news. Results, I think many people have seen this already. We set out to achieve over 20%, in fact 22% remissions at 1 year, because that was the amount that we were told would have to result in a change in the way we manage diabetes in the UK. What we actually achieved was over double that. 46% of our participants, all the participants in the intervention group, 46% were free from diabetes at 1 year, taking no medication. Their mean weight loss was, for the whole group, was 10 kilograms. So broadly, those who did more than 10 kilograms of weight loss were likely to be in remission. At 2 years, that remission rate had fallen to 36%, and the mean weight loss for the entire group was 8 kilograms at that point. And that reduction in remission rate was the result of 15 individual patients who regained weight. And they regained weight to a point closer than 10 kilograms from their baseline. And we were able to show in a sub-study in Newcastle that these individuals had regained the ectopic fat in their liver, in their pancreas, and the circulating fats in their blood. So this is one of the strong pieces of evidence that type 2 diabetes is largely caused by the ectopic fat accumulating in liver and pancreas. That fat goes away with weight loss, and if it comes back, they once again are diabetic. Remember that these people, although they lost quite a lot of weight, were still very substantially overweight. In fact, still on average, a BMI above 30 after the weight loss. So they're certainly not normal. The effect of weight loss on remissions was well sustained over a 2-year period. And you can see on the right-hand side of this slide, 15 kilograms weight loss. In the pale column at 1 year and the darker column at 2 years, both resulted in over 80% remissions. So nearly 9 out of 10 at 1 year were free from diabetes if they lost over 15 kilograms. And the results were quite good for 10 to 15 kilograms as well, but very well maintained for 2 years if they could maintain that weight loss. And what they showed us was that with 15 kilograms weight loss, only 14% failed to get a remission. And of those 14%, 11% did show improvement in their diabetes. There were about 3% who failed to have any improvement in hemoglobin A1C despite weight loss. They clearly have a different type of diabetes. And when we went into it, some of them had diabetes of much longer duration. And some of them had histories suggestive of pancreatitis or alcohol abuse in one case, suggesting that there was damage to the pancreas for other reasons than simply conventional type 2 diabetes, which will respond to weight loss. This slide simply shows the very high liver fat in people with type 2 diabetes, and I don't think we had really appreciated how important this ectopic fat is and how that falls in the blue columns with those who lose weight and get remission, but does not fall in those who fail to get remission in the greener column, or in those who relapse at year 2. So these are changes at year 2. And with the fall in liver fat, there's a fall in circulating VLDL fat. And with that, there's also a fall in the pancreas fat. And the fall is to normal. So the liver fat and the pancreas fat fell to normal in those who had remissions of their diabetes, but it regained in those who had relapses back to diabetes. And here, this simply shows the same data again, but with a photograph or MRI scan of the pancreas. And you can see on the left-hand side here, the pancreas of people with type 2 diabetes is a shriveled, sick-looking organ. Over 2 years, and those who lost weight and gained remission, it gradually filled out to become essentially indistinguishable from people who were non-diabetic. This, on the right-hand side, is a person who does not have type 2 diabetes. And you can see the volume of the pancreas became almost entirely normal. Its raggedness here, the fractile dimension, fell to normal. And really importantly, people with type 2 diabetes at baseline have very low insulin secretion capacity. They can't make insulin from their pancreas. It's a sick organ full of fat. But over 2 years, that capacity to make insulin, to secrete insulin under stimulation, returned to normal, to absolutely normal at 2 years. So this shows that the disease really is reversible, at least in the early stages. I mentioned that we had reduced and indeed stopped the antihypertensive medications on day 1. A lot of doctors were worried about this, thinking that these are terribly important drugs. What we showed, however, was that in the white line here are the people who had not been on medication for blood pressure previously, and they had a reduction in their blood pressure of around about 15 millimeters of mercury. And that is way greater than any medication can achieve. In the green are the people who had one medication for blood pressure, which was stopped on day 1. And you can see that they also had a slightly less acute drop in blood pressure. In the yellow line are the people who were on 2 or 3, or in some cases 4 medications for their blood pressure, which were all stopped on day 1. There was no rebound rise, no significant rise in blood pressure, but the blood pressures gradually fell. So at the end of the total, this shows the total diet replacement period. At the end of that period, blood pressure was roughly 10 millimeters of mercury below baseline for everybody. And that, as I say, is way greater than can be achieved by any medication for hypertension. Having said that, it's worth remembering or recognizing that amongst those who were taking 2, 3, or 4 medications for blood pressure, about a third of them, 30%, did require to go back onto one of their medications after about 6 weeks. So as their weight losses leveled out, those who didn't continue losing weight right up to 12 weeks, then they did require to go back onto some medication. But it tells us that total diet replacement and weight loss is a very potent treatment for blood pressure, and you must not continue taking the medication. Otherwise, we're going to see postural hypertension injuries. Towards the end of the DIRECT trial came along COVID. And so what we had to do really very rapidly with the Counterweight Plus program was to adapt the entire weight maintenance program to be delivered remotely. using trained dietitians and trained nutritionists who could call patients by telephone, by Zoom, by WhatsApp, by all IT methods. And in doing this, the counterweight program was then adapted so that the entire program is now delivered remotely. And the results are just shown here, so that the weight loss TDR period, 15 kilograms weight loss, pretty much the same as we had in direct. It was 14 kilograms weight loss in direct at that point. And at 12 months, the weight loss was actually greater, 15.8 kilograms, using a totally remote method with the formula diet products delivered to people in their homes. So this is a very attractive approach, which is more economical and gets equally good or even better results in many cases. Subsequent to direct, we conducted another study in Glasgow, specifically in South Asian people with type 2 diabetes, because there was a belief that the disease was different in some way. It seems to be more aggressive, occurring younger with less body fat. And the question was, are we going to see the same results? And the answer was exactly the same. And this slide shows the baseline and the control group and intervention group results for remissions in the y-axis according to weight loss achieved in the trial for direct, or Diadem-1, which is a clinical trial done in Qatar with an Arab and North African population, and for the standby trial in South Asians. And you can see it's pretty much a straight line. So the more weight loss that is achieved, the more remissions people are going to get. And the South Asian people are very close to the same line as perhaps a little greater remission rate than you would expect from the European level, but very similar. So the disease process seems to be the same in all the groups that have been examined. I've here collected together all the studies which had published remission results by 2021. There have been a few more since, but this is still quite illustrative. The randomized controlled trials at that time were just direct and Diadem-1 at the top there, which achieved 1 year weight losses of 10 and 12 kilograms, remission rates of 46%, 61%, and Diadem-1 even better than direct because they had shorter duration disease in younger people. There were also then 4 trials or four other studies which have reported results. 3 of them were using low carb or very low carbohydrates, ketogenic diets. And you can see that there, despite good weight losses, remission rates were rather poorer. I've put these crosses in the wrong place, so that should be the weight loss here. David Unwin's study showed very substantial weight loss with a remission rate of about 12% compared to our 46%, although he did report 46% remission rate in people who adhered to the program completely for the duration of almost 2 years follow-up. That 46% would correspond to the 86% which was seen in the direct trial. Other studies have been less convincing in that regard. Subsequent to that, there have now been a number of studies, as Tony Leeds mentioned, which have used what we call the direct principle, so using the same diet approach that we used in direct with total diet replacement for 8 to 12 weeks, followed by food introduction and weight loss maintenance. And these have the ones which have reported have now shown standby trial, which I mentioned, which had 40% remission rate, retune in Newcastle with people with a body mass index of 23 to 27 using exactly the same approach, 70% remissions. So you can get better rates if you can start with people who are less seriously overweight. The direct trial in Australia, a randomized trial, 56% remissions, and an observational study also in Australia, 40% remissions. So basically, this is a very reproducible intervention in different populations worldwide. The conclusions from the direct trial were augmented a few months ago with the publication of 5-year follow-up results. And these are quite exciting because they look not just at the weight and remission rate, but also at clinical outcomes. What we found was that the weight loss was 6.1 kilograms on average in the people who'd been through the intervention here. So compared to 8 kilograms at 2 years, this is a very remarkable mean weight loss at 5 years. The total remissions at 5 years were 13% of those who had data. So that has fallen quite substantially. But of course, that's at 5 years. And many of these people had been in remission for large parts of the 5 years, for quite a long period of time. And with that, we found that in the the people who'd been through the intervention had half the number of serious adverse events over 5 years. That's admissions to hospital for serious problems. And they were, more of them were free from diabetes-related clinical events. And that related to longer periods in remission, lower hemoglobin A1C during the 5 years, and sustained weight loss. And I can show them just in a bit more detail here. At the top are the serious adverse events. In the intervention group, 5.1 events per 100 patient years. In the control group, who did not have the intervention, 10.3 events per 100 patient years. That's a huge difference, and a great saving in terms of disease and of course, costs. And the freedom from diabetes-related clinical events, and that was, a lot of these were things like infections over that period, were less frequent in those with a lower body mass index at the end at year 5, lower hemoglobin A1C at years 2, 3, and 4, and importantly, a longer period in remission from diabetes. And here on the right is a little graph showing quality of life measured in all our patients in the intervention group, and showing how this increased substantially at year 1, year 2, year 3, year 4, and year 5. Now that's pretty unusual for a weight loss trial. Most weight loss trials show an immediate apparent increase in quality of life, which then declines quite rapidly, so that by 2, 3, 4 years, it has returned to normal. And that is because they haven't achieved quite the same degree of weight loss or the same clinical benefit as we saw in DIRECT, which are very motivating. Quality of life really does improve if you can lose 10 or 15 kilograms and get free from diabetes. The question, though, we were asked was, does our intervention reduce heart disease? And in DIRECT, which contained only 149 patients in the intervention group for 5 years, there was no significant effect, and no real signal that was going to happen. However, in the Look Ahead trial, which is much bigger, reported also earlier this year, with over 4,000 individuals studied for 10 years, very few of them had, or much fewer had remissions, but in those who had any remission at any point in the 10 years, there were 33% fewer cardiovascular events and kidney disease events. So it does look like remission of type 2 diabetes is at least very closely associated with having fewer cardiovascular events. And then 2 studies from an analysis of GP records in the south of England have been published, which are even bigger, 60,000 individuals studied for over 7 years. And this again found that people who were able to achieve a remission of diabetes, even for a short period of time, had lower risks of the microvascular complications, that's eye disease, kidney disease, neurological disease, and also lower risk of cardiovascular outcomes, including mortality. So if we start looking at very big numbers, we're beginning to see the same message, that remission of diabetes does seem to arrest the entire disease process if we can get it early enough. Running quickly on, European recommendations from the EASD were published in Diabetologia last year, and these have, for the first time now, included recommendations for remission of type 2 diabetes as an important target for management, a management goal, in fact, the primary management goal, and recommending that a low-energy total diet replacement program is the best way to induce the weight loss necessary to achieve remission of type 2 diabetes. And that was based on the evidence up to that time. It also recommends that nutritionally complete low-energy formula can be used as a partial diet replacement for weight loss maintenance. So the use of formula diets is kind of ratified for medical use by this set of recommendations. We also went on, and I think it's important to reflect this, that of course, using the supplements and formula diets is attractive to many people, but not to everybody. And we have a lot of pressure to use therapeutic diets. Importantly at the moment, the low-carb diets. There's a lot of noise about this, but others, DASH diet, portfolio diet, low GI diets, these are all effective and can be very effective, but they are restrictive. And so adherence in a family setting, in a work setting, is more difficult, and they can be very expensive, especially things like the portfolio diet. So difficult for adherence. Instead, we're now recommending that people should rationalize with the use of traditional diets, basically avoiding what are popularly now called ultra-processed foods, packaged foods, foods with colored paper on the outside, using a Mediterranean, Japanese, in the European setting, mainly Mediterranean and Nordic type of diets, but also vegetarian diets. And these maybe less potent than some therapeutic diets, but they're cheaper and easier for families, so probably better for long-term adherence to maintain weight loss and remissions. And just throw away here the recent meta-analysis of all the low-carb diets. This is because of all the noise about low-carb diets, which is, it's very hard to know quite who is driving it all now. There are commercial organizations, of course, but the evidence when you compare low-carb versus high-carb diets is there is no different effect on body weight or on hemoglobin A1C or on lipids or blood pressure. So there's a lot of noise there with no effect. Good news published just last week or last month, sorry, was that the UK, or rather NHS England, should I say, Path to Remission program, which is using the Direct Principles program for 10,000 health service patients in England, not using the original counterweight program, but something others like it, have now reported pilot data in over 7,000 individuals. And what they're showing is a 28% remission rate at 12 months. That's shown here with the different weight losses, different remission rates according to weight loss. And what you can see is, again, the weight loss of 15 to 20 kilograms or more is resulting in a 50% remission rate here. So perhaps not quite as good as direct, but very similar and certainly eye-catching and striking at a population level if you can get half of people to be free from diabetes by losing over 15 kilograms. And importantly, I've pulled out one other slide from that publication or presentation at Diabetes UK, which is showing that the remission rate is substantially greater if you can catch people early. So under 1 year, 38% remissions, above 4 years, 4 to 6 years, 18% remissions. So it's a doubling of the remission rate if you can catch people within the first year after diagnosis. But this is a nasty disease, it progresses, get it early. And news last week was that the NHS England programme is going to be expanded with another 10,000. They're so pleased with it, another 10,000 will be put in, and this is going to be now spread across the country, and it will use, for some of them, the original Counterweight Plus programme delivered remotely. So we hope to get even better results there. Final remark, I mentioned not everybody will want to have a total diet replacement or formula diet. In Scotland, we're very fortunate that we have a traditional diet, and here it is. This is my diet on a day a couple of months ago when I photographed it. Bowl of porridge in the morning, a bowl of lentil soup at lunchtime, and then in the evening I was simulating my patients who are trying to lose weight, another bowl of lentil soup with a piece of fruit at each meal and 2 pieces of bread. Now that gives you a nutritionally complete meal of about 850 calories. All the micronutrients are there. It's also traditional. Most people like these foods. It's boring, but you don't want people taking second helpings during a weight loss program. And once they've achieved the weight loss, we then ask them to vary one meal, which is usually the evening meal, to make it more varied and to be able to eat with their family again. We've done the same sort of thing in Nepal using one of the traditional diets used in Nepal, which is dal bhat, rice and a dal or lentil soup with vegetables. And again, if portion control is in place, that can give about 850 calories and be complete for micronutrients, provided we have a milk-based breakfast as well. And these are now being used. And here's very early data, not yet published, so don't broadcast this too widely, showing how in a study of 70 people in Nepal, how we were able to achieve a 29% remission rate at 1 year, which is very comparable with what is seen in NHS England in their rollout program. These are patients who started off substantially overweight from Nepali people with a duration of diabetes 2.5 years. Hemoglobin A1C was very high, 8.1% on medication. So getting that remission rate was very striking and a good omen for the future. Here's my conclusion, that type 2 diabetes is a huge disease, but it's preventable and reversible into remission by weight loss, and we shouldn't wait to put that into practice. Patients themselves are calling for it, and healthcare services are expanding to provide that service. The most effective intervention currently use formula diets to induce the weight loss, and meal replacements can be used to contribute to long-term weight loss maintenance. And on that happy note, I'll say thanks very much for listening if you did, and happy to answer any questions.
Thank you very much indeed. Thank you. Well, 1 or 2 questions have appeared, and there's one that in which an individual says, would the use of GLP-1 agonist medications have produced equivalent outcomes in all the various variables that were measured by comparison with total diet replacement?
Well, that's a sort of roundabout question. What you can certainly achieve with GLP-1 agonist drugs and their successors, tirzepatide, for example, is very substantial weight losses without the use of a formula diet, or perhaps with the use of a formula diet to help induce the weight loss before starting the drug. And both those studies have been done. The weight losses are very substantial, and they're now beginning to rival what can be achieved with bariatric surgery. So these drugs really are here to stay, and they're making a big impact, as you of course know. What you can't do with a drug is to produce a remission of diabetes if you're giving a drug that reduces blood glucose, which they do. So you'd have then to induce the weight loss and then maintain it without the drug in order to demonstrate that you've got a remission of type 2 diabetes. That can be done, and we've done it in small numbers of people when they withdraw the drug, such as semaglutide, using the weight loss maintenance program that we developed for Counterweight Plus. So that is possible, and there may well be a role for meal replacements in doing that. So to induce major weight loss with a medication, with quality of life improvement, functional improvement, if we can then maintain that in the long term, either using intermittent formula diet, as Professor Bliddal has done in Denmark, or using meal replacements on a regular basis. Both of these seem to be acceptable, but it can be done with dietary means alone.
Yeah, thank you. There is a question: what was the macronutrient composition of the diet, the traditional diet that you've used in Scotland?
Oh my goodness. I'd have to go back and do some calculations on that.
Well, with the food,
you caught me on the hop. I haven't actually got the data. You were talking about the sort of porridge and lentil soup type diet, and that, of course, that is a diet for weight loss. And so, in a sense, the macronutrients don't matter very much. If you're on 800 calorie diet, it really doesn't matter what your macronutrient intakes are going to be. The protein intake would be relatively low on that, so it's probably around about below 15%, but ample, adequate for a person who's losing weight quite rapidly. It'll be relatively high in carbohydrate and pretty low in fat, very low in fat.
But also because of the high amount of oats and lentils, you would have a high content of dietary fiber, and particularly soluble fiber, which of course slows down carbohydrate absorption. So
a bit, yes, and also it does prevent some of the constipation, which otherwise is a problem. Yeah. So we use that. I mean, a lot of people have used this, and it's available online. Anybody can do that. And I have letters and people saying, "Oh, we followed this, and wonderful. We've got free from diabetes with no cost." Not everybody can do it, but we really should signpost this as an approach for people who want to get clear of their diabetes and are prepared or have the discipline to follow a diet of that type.
Yeah. There's a question from Kelly Johnson. Have other types of diet been used in relation to the effect on the pancreas? In other words, you've got the evidence that the Newcastle work that showed the effects following the TDR use, but the low carbohydrate diets or the keto diets, for example, do we know why those perhaps are not as effective?
We don't know that yet. We don't know what's going on there, but there is something about high carbohydrate diets which can be hazardous to some people in some situations. As you probably know, Arne Astrup has done some study, and Sue Roberts, I think, also suggesting that there may be something unusual going on. And I think it could be that people are gaining weight. If you're going to put on weight, gain fat, then to do that on a high carbohydrate diet is probably a bad idea, because you're more likely to deposit palmitate in your ectopic fat, and that palmitate is a little bit more toxic than other fatty acids. So dietary fats are less hazardous than the fat which is made out of carbohydrate if you're eating excess carbohydrate and gaining weight. But if you're maintaining your weight or losing weight, then having more carbohydrate isn't a problem.
So finally, there's a comment from somebody. Is it possible to share the slides? I'll discuss that with you and with Henning, and we'll see whether anything can be.
In principle, Tony, I years ago I used to say, no, nobody. I'm never going to show my slides because I know people will steal them and show them and pretend that they're their own lecture. And I came across people doing this in North America, showing exactly my lecture with their name on it, which upset me at the time. In fact, I was really quite shocked as a young researcher. Now. I'm just keen that everybody should get hold of these data, so I'll put them up online if I remember.
Okay, thank you very much. Well,
there's a direct clinical trial website where there are already quite a lot of slides, and now you've reminded me, I will put up some slides, perhaps these exact ones.
What we will do afterwards, we will circulate to all those who attended this meeting the links to all those sources, and also, of course, this video recording will be available as well. I think now, I'm just watching the time. We're coming to the point at which we need to close, so I think I need to conclude. Thank you very much indeed, Mike, for that brilliant summary of the position where we are. We're at a very exciting point in time, aren't we? Because we know that there are lots of other trials taking place, and we're waiting for the results of those and trying to roll this out in other countries. So that's really good. You did mention the health economics of this, and there are 1 or 2 published studies in that. And then you mentioned that we need to try to choose the most cost-effective ways of doing these things, which, following my discussions with some of your colleagues in Scotland, it does seem that digital delivery is probably more cost-effective than delivery face-to-face or in groups with healthcare professionals.
Well, you can do digital delivery with groups as well, so that makes it even more effective. So yeah, I mean, I think the future absolutely lies in remote delivery and IT support.
Yes.
IT can include the telephone. It's extraordinary. This great Scottish invention, the telephone, has suddenly been rediscovered through COVID. And we're now using it in medical care and in NHS practice. We never did before, very seldom.
Yes. Yeah. So, and then also, I think you suggested, and I know you've written this in some of your reviews, that the real challenge, of course, is to achieve ways of achieving weight maintenance in the majority of people rather than leaving out a small proportion.
Yeah.
So there's more work needs to be done there. But I think we need to conclude now. So thank you very much indeed for your contribution. It's great. We will circulate more information to everybody who's participating. So thank you to you, Mike, and also to Henning, of course, who's had to leave to go to another meeting. But also thank you to the White House team, Zoe and Aris, for making the organisation. And there will be a lot of follow-up material. So this doesn't end here. You will hear more from us. So thank you very much all for participating. Thank you to all the delegates who've attended. And we will no doubt have follow-up meetings later on. Thank you very much indeed. Thank you. Bye-bye. Bye. Thank you. I declare the meeting closed.